Hello, and welcome to ID Talk, answers from infectious disease experts. I'm Dr. Scott Olson, a pediatric infectious diseases specialist at Banner University Medical Center in Tucson, and associate professor of pediatrics at the University of Arizona College of Medicine. Along with Dr. Nathan Price, I'm the Arizona AAP Infectious Disease and Immunization Co-Medical Director. And if you're looking at the thumbnail of the podcast, Dr. Price is the distinguished one on the right, and I'm the one on the left. This podcast has been created to answer questions from our chapter members about anything and everything infectious disease and immunization related. Thanks again for tuning in today. This is the week of November 18th, 2024. We've had some great questions sent in by AzAAP members, so let's go ahead and jump right in. The first question submitted this week asks, can you explain why it's difficult to detect walking pneumonia through standard bacterial cultures? This is a good question, and I'm guessing the sender listened to our episode in late October where we discussed the rising incidence of walking pneumonia in the United States over 2024. I think it's good to take a second and go back to review what exactly walking pneumonia is before we talk about diagnostic methods of detection. Walking pneumonia is the lay, non-medical term for what we would otherwise describe as atypical pneumonia. While most typical pneumonias in children are the result of infection from organisms such as Streptococcus pneumoniae, Haemophilus influenza, or other respiratory pathogens, atypical pneumonia is most often caused by Mycoplasma pneumoniae or Chlamydia pneumoniae, which used to be called Chlamydiophila. As opposed to the pathogens that cause typical pneumonia in children, atypical pathogens tend to present with less severe symptoms. Additionally, while typical community-acquired pneumonia occurs in infants and children less than 5 years old, we see an increasing incidence of atypical pneumonia in school-age children and those over 5 years. If you can remember from my last episode in October, in 2024 we've been seeing a significant increase in incidence in the United States of atypical pneumonias, including among children less than 5 years old. But part of what has made characterizing the current epidemiology of mycoplasma and atypical pneumonias difficult is the fact that it is a very difficult organism to culture, getting back to the initial question of our listener. So why is that the case? If we in infectious diseases rely heavily on culture data to guide our therapy, then why is it that we have such difficulty culturing mycoplasma and other atypical pathogens? The short answer is that these organisms don't tend to grow well on the standard cultures that are used in microbiology labs. There are culture media that can be used to yield growth of mycoplasma, such as Eaton's agar or selective diphasic media. However, these are not typically used in most microbiology labs. Additionally, because these organisms lack cell walls, they don't take up the stains that we use for gram stains for identification, and therefore these are organisms that are difficult to identify by standard light microscopy detection. Thankfully, multiplex PCR assays are quite good at identifying mycoplasma and Chlamydia pneumoniae organisms off of a nasopharyngeal swab. For example, the BioFire multiplex PCR reports a sensitivity of close to 98% for detection of mycoplasma with a specificity of 100%. In this context, because PCRs are so sensitive and specific, and because identifying these organisms on culture can be difficult, timely, and costly, culture doesn't have a lot of utility when we are diagnosing atypical pneumonias. I realize that this is a little more difficult in outpatient settings where it may not be possible to send a respiratory PCR. I think in these settings, I would continue to think of atypical pneumonias in patients who present either over 5 years or if they have significant constitutional symptoms, a known exposure to someone with a diagnosed mycoplasma infection, or they simply are not improving on antibiotics that should treat the typical pathogens after about 48 to 72 hours. And remember that in children, macrolide antibiotics such as azithromycin are the recommended therapy. One last thing I would like to add before we move on for this question is just to remind providers out there that in most circumstances, mycoplasma antibodies are not really useful for diagnosis because they lack sensitivity and specificity. There are some rare contexts where I find them useful, but for outpatient practice when dealing with atypical pneumonias, I would tend to advise against using serologies. And now moving on to our second question, a listener asks, would you recommend administering Mpox vaccines to children? And how can we determine if a child is at risk for Mpox? Before we get into the recommendations for vaccination against Mpox, I think it's useful to pause and review a little bit about the disease, in part because I think it helps us understand a little bit the rationale for the recommendations currently from the CDC regarding vaccination. So Mpox, or monkeypox as it used to be known before it was reclassified, is a species within the orthopox virus genus, which includes other viral pathogens such as smallpox, cowpox, and vaccinia. And the virus is spread person to person primarily through direct contact. So it doesn't seem to be a virus that spreads easily through either droplet or certainly not airborne routes. There are two separate viral clades with multiple different subclades. Now, most of us probably became familiar with Mpox back in 2022 when there was a global outbreak of clade 2 Mpox. And I think this is what most of us remember reading about. Now, that outbreak has subsided with currently almost no circulation within the U.S. in 2024. However, there is currently an outbreak of clade 1 Mpox that has been going on in Central and East Africa this year, with some travel-related cases that have been identified outside of that region, including cases within the United States. During the outbreak that occurred in 2022, the majority of cases identified outside of the endemic region in Central and East Africa were within MSM populations, and therefore the initial recommendations for vaccination focused on that population. With regard to pediatric cases, at least within the United States, the majority of identified Mpox pediatric cases were in individuals who had direct contact with a known adult index case. So I think knowing this background helps us understand a little bit better the current CDC recommendations for immunization against Mpox. As of now, they recommend that those individuals who are at risk should receive a full series of Mpox vaccine, and those at-risk individuals include patients who are gay or bisexual and in the last 6 months have had one or more sexually transmitted infections, more than one sexual partner or anonymous sexual or intimate contact, sex at a commercial sex venue, or sex in association with large public events in a geographic area where Mpox is being transmitted. Additionally, the vaccine can be used as post-exposure prophylaxis, and in this scenario, the CDC recommends consideration of use as prophylaxis if your patient has had sexual or intimate contact with a person who is at risk for Mpox, or if they have had similar contacts with someone who may have Mpox. Currently, there is one FDA-approved Mpox vaccine on the market, and as of now, it is licensed only for those 18 and above. However, the CDC does recommend that adolescents who are at risk for acquisition of Mpox can also be immunized with the Jynneos vaccine. Similarly, for patients less than 18 years old who have a household contact or other close contact who is diagnosed with Mpox, those individuals can receive the vaccine as post-exposure prophylaxis. One consideration to keep in mind is that if you are using vaccination as post-exposure prophylaxis, though the incubation period can be up to 21 days, it is recommended that the immunization be given as early as possible and preferably before 4 days following the exposure. However, there's probably still some benefit up to about 14 days following exposure. Though in these circumstances, the assumption is that vaccination in that time frame may not prevent disease, but mitigate the severity of it. So when it comes to immunizing against Mpox in the pediatric population, there are really two separate categories that I think you need to remember. The first group is high-risk adolescent patients who, at least based on current CDC guidance, can be immunized against Mpox with the Jynneos vaccine. And I may have failed to mention this earlier, but when you are immunizing an individual, they need to receive 2 doses at day 0 and day 28. The second category of pediatric patients to consider would be those who are exposed to household contacts with a known Mpox case. And in that scenario, post-exposure prophylaxis is recommended with a single dose and hopefully within the first 4 days after exposure. Now, one last thing I did just want to mention is that currently the recommendation is that the Jynneos vaccine should not be used in individuals less than 6 months old. So that then begs the question of what do we do for infants who may have had a direct exposure? And in these patients, the recommendation currently is that for post-exposure prophylaxis, they should be receiving vaccinia immune globulin. Now, here's where I have to admit that I have never used vaccinia immune globulin in any of my patients, and I hope I don't have to. But if ever needed, it is available through the CDC, and you would have to work with your local health department to acquire it. The last thing I want to mention before we move on to the next question is that we are still fairly early in this current Clade 1 outbreak of Mpox, and it's going to be interesting to see how this evolves over the next several months. So possibly more to come as we get further guidance from the CDC. And moving on to question 3. Another listener writes in, how can parents protect their newborns from unvaccinated friends, family, and children? Topics like this tend to cause tension in families with varying beliefs, and how can we advise parents in these situations? Oh boy, well, this is a tough question, but because the holidays are coming up, I do think it's timely. First thing to say is that there is not a lot of data to guide my answer here, so I'm just going to tell everybody what I tend to counsel families about when this question comes up. Second thing to say is I have to admit that I may not be right here. So if you're a listener and you have great ideas or how you normally address this question, please feel free to email in. I'd love to hear responses. I think the first thing I'll say is that we know from studies on things like respiratory viruses, so for example, RSV, in most circumstances, it's a direct household contact, whether sibling or parent, who brings the virus into the household and eventually leads to infection in the at-risk infant. So why do I bring that up? Well, first thing I would say is really make sure that you cocoon the infant by immunizing everyone in the family or everyone in the household so that those illnesses are not brought in and the infant is not exposed. Then the next question is, well, who is important for you to have around during those first few months of the infant's life? Is it important that grandma and grandpa come to visit? Do you rely on Uncle Bob and Aunt Jill for family support? And unfortunately, that answer is different for every family unit. So I think you kind of need to interrogate, first of all, what is necessary in terms of family support, both when you're talking to the patients and then really pushing them to answer that question for themselves. Then if there are family members who are either vaccine averse or vaccine hesitant, I think you just have to have an honest question and say, we have a young infant and we're trying to protect their health. And if those individuals are still unwilling to be immunized, then I think you just have to ask that they respect your values and your beliefs and that they stay away from the infant at least until the infant is past the high-risk period of infancy or immunized against those infections that we can vaccinate against. And if those conversations become difficult or heated, I always tell parents to reorient back to why they're having that conversation in the first place, and that's to protect the health of their infant. Lastly, and maybe a little selfishly from a public health standpoint, I also think it's important that parents and family members be willing to voice their support of vaccination. We know that individuals who are vaccine hesitant don't often listen to top-down messaging like from the CDC or state health departments, but if they hear from their immediate family members who they love and trust that vaccines are both safe and effective at preventing severe disease, then maybe some of those individuals will start to question their own stances. So spread the news and tell all of your patients and families that this year, along with the pumpkin pie, mashed potatoes, and gravy, maybe they can serve a little bit of vaccine advocacy on the side. And this brings us to our fourth and final question of this week. One listener wrote in, what is the safest bug spray on the market for children that has been proven to work against mosquito-borne illness? What are the ingredients in bug sprays that parents should avoid? I really like this question for a few reasons. First of all, I find vector-borne diseases just incredibly interesting, and certainly we want to protect our patients against those diseases that are out there, such as West Nile virus and other arboviruses, Lyme disease, Babesia, Anaplasma and Ehrlichia, but also personally because having grown up camping in northern Wisconsin, to me, the smell of summer is DEET. So that being said, let's get into which products are on the market and which of them are recommended for children. In general, products that contain DEET are still considered the most effective means of mosquito repellent, and they're also fairly effective against ticks as well. Now, when you look at products that contain DEET, you want to look at what concentration the DEET is at. And that doesn't necessarily suggest that a higher concentration is more effective against mosquitoes. It just tells you how long it's going to stay active on someone's skin. So, for example, if you have 10% DEET, the estimate is that it's effective for about 2 hours. And if you go up to 30% DEET, it's effective at around 5 hours before you'd have to reapply. Now, there are products on the market that contain up to 50% DEET, but since 30% protects for up to about 5 hours, there's not a lot of use for higher concentrations for most of our patients. Now, DEET is considered safe and it is approved by the FDA, but it's recommended not to use at concentrations over 30% in children. As I mentioned earlier, DEET is considered safe, but the concern is that at higher concentrations, it could either cause local irritation if on mucous membranes, and for very young children who regularly have DEET on their skin for long periods of time, there is some concern that it can lead to neurotoxicity and seizures, which is why DEET-containing products are not recommended for children less than 2 months old. I think most of us are used to discussing DEET when it comes to bug spray, but it's important to remember that there are other options that are deemed safe and effective by the EPA. Some of those include picaridin, which has similarly good protection against mosquito and ticks when compared to DEET. However, it may have a shorter period of activity. Therefore, it's important to counsel families to follow the instructions on the label closely. Now, one of the benefits you'll hear from people of picaridin over DEET is that it is an odorless compound, which, as I mentioned earlier, if you grew up using DEET-containing products, there's a very distinct, sometimes acrid smell. A third agent on the market is a product called IR3535. Now, this is interesting because it was initially developed as a skin moisturizer, but then was found to also have good bug repellent properties. Now, this seems to be effective against Culex and Aedes mosquitoes, which tend to be the predominant species here in the United States, but it doesn't seem to be as effective against Anopheles mosquitoes, which transmit malaria. So if you have families traveling internationally, these IR3535 products are probably not the way to go. If you have families that are going to be spending a significant amount of time in tick-endemic areas, you're probably going to want to counsel them on considering use of permethrin. Now, permethrin is not safe when it's used directly on skin, so it's something that needs to be applied to clothing, either as a soak or as a spray. But what's great about this product is that it's considered the most effective for tick repellent. So again, it is really useful if families are doing camping or hiking or anything in a part of the world where you're really worried about tick-borne illness. But because it can't be used directly on the skin, I would say it should be used as an adjunct with something like a DEET or picaridin spray administered on the exposed skin. Last, there are some more natural products on the market, including oil of lemon eucalyptus compounds. These seem to be at least safe. However, there really is not a lot of efficacy data on their use. And in particular, you'll see that the EPA recommends that we do not use those in patients less than 3 years old, mostly because it hasn't been studied extensively in younger children. When using any of these bug repellents, it's important to remember a few additional items. First, since presumably these are patients who are going to be spending time outdoors, if it's during the summer or a time when there's going to be lots of sun exposure and you're using sunscreen, the sunscreen should be applied first with the repellent then applied on top. Additionally, because most of these compounds can be irritating to eyes or the mucous membranes, parents should be applying these products to their children's skin, making sure to avoid the face or eyes. Many experts also recommend not applying bug repellent to the hands of younger children, just in case they may accidentally ingest it if they place their hands in their mouth. The last category of insect repellents that I'm not going to spend a lot of time on is those that are more naturally derived compounds such as citronella or peppermint oil. Now, these are deemed safe by the EPA, but there's not a lot of data on how effective they are. They probably have some short-term efficacy, but they probably don't maintain their efficacy as long as DEET or picaridin compounds. So if you have families that are interested in using them, I think it's important to point out that these are products that would have to be reapplied fairly frequently. Lastly, though I know this was not the intent of the question, I'd like to just point out really quickly some of the other interventions that are important to prevent vector-borne diseases. Here in the United States, since a lot of tick-borne illnesses require that the tick be attached for a prolonged period of time before transmission, it's really important to counsel families that at the end of each day, particularly for their younger children, they should be conducting tick checks over the entire skin, particularly in difficult to visualize locations like skin folds or at the crease of the socks or the waistline. And for those families who are traveling internationally to areas of high vector-borne diseases such as malaria or dengue virus, it's important that they understand how to avoid mosquitoes while travel. And for those individuals traveling to highly endemic areas for malaria, that they also travel with appropriate malaria prophylaxis. Vaccinations against vector-borne diseases such as yellow fever and Japanese encephalitis are available. However, these vaccines should only be administered to those who are at risk based on their travel itinerary. And that's it for the week of November 18th, 2024. Thank you again for listening. Remember, AzAAP members can submit questions for future episodes to id@azaap.org. The AzAAP would like to acknowledge the generous support of the podcast by the Arizona Department of Health Services through the Title V Maternal and Child Health Services Block Grant funding. For more information and resources related to infectious disease and immunizations in Arizona, or to become a member, visit azaap.org. As always, thank you for these interesting consults, and we'll see you next time on ID Talk.